Is my stem cells going to take? That's a big question people ask. So am I going to reject the stem cells? You know what? That's a rare event. I would estimate it happens in no more than 5% of the cases. Very often it may happen a little later because of an infection that will suppress the cells. So we match so well these days, even with unrelateds, that rejection rarely occurs. There are side effects from when the blood counts drop too low. So you can have bleeding because your platelets are too low, infection because your white cells are too low. You can have chronic problems because you may inflame an organ. You may inflame the liver, give you something called veno-occlusive disease of the liver or pneumonia. The biggest side effect with a allotransplant is something called graft-versus-host disease. And for argument, graft-versus-host disease is exactly the opposite of rejection. Instead of you rejecting the stem cells and other cells that come in with them reject you. And this may affect some of the organs in the body. There's acute form and a chronic form, but it can affect your skin and your gut and your liver. And it can be quite serious. It can be something from as mild as a very mild rash to something that looks like a third-degree burn in its worst cases. And this is kind of what you're dealing with. Now, for the majority of cases like this, we can control it. But controlling it means really cranking up the immunosuppression. And cranking up the immunosuppression increases the chance of infections. And not routine infections, infections with very bizarre organisms, so unusual viruses or unusual molds or funguses or bacteria that you normally wouldn't see. And that much of the, when we talk about people not making it through the transplant because of toxicity, much of it is because of the side effects of treating graft-versus-host disease. And that is one of the biggest side effects that occur. Now, as I said, we don't totally want to do away with graft-versus-host disease, particularly if we're transplanting for a malignant or pre-malignant condition. Because people who don't get graft-versus-host disease have a higher chance of relapse than people who get a little bit. But it's kind of a two-edged sword. A little bit is good, too much is no good. So there could be chronic problems. It can do things like young women, it can make them infertile. It can make many women prematurely menopausal. With males, it can make them infertile. It can cause problems chronically so that people may get the kind of diseases you may get if you have a bad autoimmune disease, so profoundly dry eyes, so that you're constantly having to put drops in, or a dry mouth, or problems with the lungs that may chronically lead to some breathing issues. You may cause cataracts. And one of the things that does occur is transplant patients have a higher incidence than the normal population of getting a second type of cancer. Not relapse, a second type. So one of the things we're constantly telling our patients is, this is why I got on my smoking kick, because we have cancers of the mouth and the throat that are a big issue. 2, skin cancers. So going to Florida and sitting in the sun after your transplant is a no-no for the rest of your life after a transplant. Making sure if you're a woman you get routine pap smears. If you're a man, getting routine prostate examinations, including a PSA, which are things, for instance, that the family doctors say is not something that you should do in a routine situation. Well, you're not a routine patient. Making sure when you hit 50 you get that colonoscopy and get it repeated as necessary. So there's a lot of these things that are potential issues in the chronic phase if you get through the course that you have to worry about. The best way to avoid this is to be smart. Don't do stupid things. But secondly, also to maintain contact with a transplant center where they know what to look for. So I do mammograms or MRIs of breasts on 20-year-olds who've had transplants. They have a higher risk. You know, no one would ever do a mammogram on a 20-year-old, but we will. And although the guidelines talk about you shouldn't do a mammogram before the age of 40, it's a no yield, that's the normal population. You know, our increased cholesterols are a big issue post-transplant. We need to get very aggressive about treating increased cholesterol. You know, the family docs don't put that into the perspective of a post-transplant patient. So there are a number of potential issues that require long-term follow-up. And I've had a number of patients who we transplanted, follow up for a few years, and then disappear off the planet, and then show up several years later with something big that probably could have been avoided. A transplant fails for 3 reasons. Number 1, you reject the graft. 2, the original disease comes back. 3, a transplant-related complication. Okay, so in the case where you reject the graft, very often we can regraft, something that might be doable. 2, a transplant-related complication. Well, if we can't control that complication, there's not much we can do. So the big question comes up, well, what if my original disease comes back? Generally, if your original disease comes back in less than 6 months to a year, there's not much we can do successfully. Because whatever has been there has survived what you've tried to do with the transplant, either the ablative chemotherapy or the immune effect, the graft-versus-leukemia effect from the transplant. Ones that are out a little longer, on occasion, if an individual is healthy enough, a second transplant might be considered. Although the yield of that is much lower, the toxicity much higher, the number of issues. Sometimes we could actually try and get T cells from the donor and use them to enhance the graft versus tumor effect. You know, if it comes back early, sometimes you may be able to change the immunosuppression so that you induce the graft versus tumor effect.